Hello, everyone. Welcome to our live Q&A this afternoon. We have Dr. Jain with us today, talking about starting fertility treatment. How are you, Dr. Jain?
Good. I hope everyone's doing good. Grabbed a snack or lunch, something, just to sit back and relax for the next 30 minutes.
Yeah. Let's get right into it. I see a bunch of people joining. Welcome, everyone. We are going to go over a little bit of our topic today. I'll turn it over to Dr. Jain to talk about starting fertility treatment. Maybe you can tell us a little bit about how do you know when it's time to seek fertility treatment or go see a doctor, and what happens in your initial consult. Maybe a little bit info on the initial tests and evaluations. We'll turn over.
That's perfect. So I think the first question that a lot of people wonder is it too early to seek care or to seek a fertility consult? And the answer that most fertility doctors will say, if not all, is it's never too early. So seeing a fertility doctor before you even ready to even start thinking about it, that's pretty much when I would start thinking about seeing one of us. And I call that preconception screening or preconception counseling. And it's just a way for us to get to know what's going on in your body. Is there something that might be coming in the way of you trying to conceive? Or is there something that we can work on before you actually start that chapter of your life? So that is the biggest thing, right? The timing. And then I think about, what should we be looking for, right? When you're coming in to start your trying to conceive journey. I think the biggest thing that we're looking for is there any genetic issue that's coming in the way between you and your partner? We rule out a lot of labs that might be coming in the way, like endocrine disruptors or your TSH or prolactin, things that might be off from your pituitary gland where your reproductive hormones come from. And then we look at structural issues. And of course, the semen analysis for us is right up front. We do that at the same time as we do the female workup, we do the male workup. But I think it's important to just break it down into those big categories so that you can better understand that this is actually not so overwhelming if we think about it one step at a time.
Beautiful. At this point, we can welcome everyone to type in your questions. If you want to ask Dr. Jain any specific questions about yourself or your situation, your fertility journey, anything that you have in your mind. I'll get us started with a couple of questions just to get it going. One of the questions that we commonly get is, do I need a referral to see a fertility specialist?
So I think that depends on the state and also on your insurance. You technically don't need a referral for a majority of insurances in the state of New Jersey. You can search us on Google or, whatever, even on Instagram actually, and you can just click and make an appointment with us without actually needing a formal referral. So it's very, very easy to get in touch with us.
Lovely. And then another common one that we hear is, should my partner come to my initial visit?
Yes, so I 100% recommend partners come. Even if a patient comes and I have a female patient and her partner's not available or is at work or is taking care of any children at home, I ask them to FaceTime them in. So that way everyone's a part of the initial visit and can ask any questions. Because the first time you see an REI or someone like myself is really just the time to get to know each other and to understand your dynamics at home, what your biggest questions and what your biggest even dinner table conversation starters are when it comes to fertility, because that can help me play a role and understand how I can help you better just by getting to know that interpersonal.
Lovely. And then maybe we can talk about some of the tests that we usually do and how long does it take between the initial appointment and getting to those tests and all of that.
So between the initial appointment and getting your tests, it's usually just a few weeks. The lab work we do, every practice is a little bit different, but at RMA, we do your lab work the same day as your visit. So when you come in, everything starts by you getting to know our clinical staff and getting your vitals done. And then you have full hour-long consults. Usually it's like 45 minutes-ish with one of our providers. And then that part is just getting like history and understanding your background and getting to know what your biggest concerns are in the fertility journey and the workup. And then we go over and we do an ultrasound. And during the ultrasound, we're taking a look at your uterine shape using a 3D ultrasound, and we're taking a look at your ovaries and ruling out any big structural issues that we might find. And then you meet your nurse, either in person or via phone. And then you get blood work done. And both you and your partner, the benefit of coming together is so that both of you can have your blood work done right up front. And the reason we like the blood work done is because the genetic panel that we do, the expanded carrier screening, can take about 3 to 4 weeks to come back. And that's usually the thing that pushes us back in terms of starting our fertility treatment. So sometimes it's nice to actually have it done before you even see us. But if you don't, no worries. We just do it at your first visit. And then once that comes back, then we can actually start your fertility treatment after making sure that there's no, overlapping genetic diseases. So the lab work and the ultrasound happen the same day. The semen analysis is scheduled a week or 2 later, or even sometimes the same week. That kind of just depends on our workflow and the availability of visits and which office you prefer to go to. Imaging. So either a saline ultrasound, which happens with your provider or one of our colleagues, which generally takes place between day 6 and 12 of your period. So it depends. If you're day 3 and you're coming in for your first visit, you can have your saline ultrasound just a few days later. And that's what I do for a lot of my patients. And then the hydrosalpingogram, or the HSG, the tube test, is very similar. We do it between day 6 and 12 of your cycle. So it can happen pretty much a few days after your visit if you come in early and we have availability. Or if you're in the second half of your period, then we wait for your following period and do the testing then. So all in all, I would say a few weeks really to get that basic testing done. And then you always have a follow-up phone call or a telehealth or an in-person visit with your provider so that you can talk through what makes sense and if something stood out from your workup.
Lovely. Thank you so much for all that explanation. We have a question, and it's asking, does a hydrosalpinx, and I'm sorry if I read that wrong.
Hydrosalpinx.
Perfect. Cause a biochemical pregnancy?
That's a great question. So having a hydrosalpinx, first, I'm sorry that if you have a hydrosalpinx, it's a really tough diagnosis because you start going down this rabbit hole of like, what caused it? Do I have other risk factors? Am I ever going to be able to get pregnant? I'm sure all these questions go through your mind. And I want you to feel first, it's great that we know, right, that you have a hydrosalpinx because it can absolutely interrupt a pregnancy. The role that your fallopian tube plays in a pregnancy is really as a tunnel and also as a fertilization kind of host for the egg and the sperm. So that's where the egg and the sperm meet in your tube. But if that tube is dilated, then structurally, it's going to be a little bit harder for that embryo to get into the uterus because it just doesn't have that tight tunnel, the peristalsis or kind of tube. It's hard for that embryo to get there. So a lot of the times having a hydrosalpinx can lead to having a negative pregnancy test because the embryo never makes its way over to the uterus. The other thing that it puts you at risk for is an ectopic pregnancy. So if the embryo gets stuck in the fallopian tube, then the cells start multiplying. They really try to do their job, but because it's in the tube is very constricted, very skinny kind of anatomical structure, so it can get stuck, and that can lead to an ectopic pregnancy. A hydrosalpinx also has this chemical fluid. I like to think about it as like inflammatory fluid that can leak into your uterus, and it can interrupt an early pregnancy and even lead to a negative pregnancy test. So it can play a role in having a biochemical pregnancy where the embryo tried to implant, but there were some inflammatory factors at play, and it interrupted the progression of the pregnancy. That's why if you have a hydrosalpinx, we always recommend having the tube removed before we implant an embryo. And I know it's a lot, it's a big surgery, but it does boost your chances of a happy, kind of successful pregnancy down the line.
Awesome. Thank you so much. And maybe a question is, when considering a clinic, how much emphasis should you place on the lab and where they store the frozen eggs or embryos?
That's a great question. In terms of the lab, I always tell all my patients, the reason that I'm at RMA is because of our embryologists and because of our lab, because I just think that they are the gold standard. And at the end of the day, you can see any of our providers. I love my colleagues. I'm lucky to work here. And I don't say that because I'm doing a live with the RMA network. I say that to my patients. I say that to my family, to my friends. This is a really, really nice place to be both as a provider and as a patient. And the reason that I really put an emphasis on the lab is because that's where the magic happens, right? We do the egg retrievals. The technique is pretty much the same no matter what practice you go to. Stimulation protocols, we do tweak them here and there, and I think we're very individualized here. So every patient can get a different protocol. Like a 35-year-old next door can have a completely separate protocol than you as a 35-year-old. But the lab makes all the difference. They work so hard to maximize and make the optimal conditions for your embryos, that I think that's what makes the magic, really. So yes, lab has a huge emphasis. Then it comes to storage, right? I think storage is a really scary thing, especially, thinking about where my embryo off doing my life and doing the things that I'm doing between my embryo transfers or waiting for pregnancy if you're pursued egg freezing. I don't think it makes that big of a difference whether it's on-site or off-site storage. At RMA, we actually do a combination of both. We have on-site storage and off-site storage, depending on how long you're waiting between the time of freezing your eggs and embryos and pursuing the embryo transfer or coming back to thaw and use those eggs. And I trust both of our locations, and that is the same pretty much for any lab. There is so much monitoring, so many security guidelines in place to make sure that we're meeting the standards that we need to meet to keep your embryos and eggs safe, that where it's stored doesn't play that big of a difference. But I think on the front half, again, with the lab, right after your retrieval and with fertilization, that does make a difference.
Awesome. Thank you so much. And then we have another question, which is, when do you recommend an SIS versus an SHG?
Yes, so the difference between an SIS or a saline ultrasound and an HSG or hydrosalpingogram is basically what we're looking at, and then also the type of test. A saline ultrasound takes a look at the inside of the uterine cavity. So it's very similar to regular ultrasound that you would get in our practice, that we usually do during like morning monitoring or if you're in an IVF cycle. But the difference is that we're putting the lining, because our lining just wants to stick together, and that's what leads to that thin kind of appearance that we measure all the time on ultrasound. But a saline ultrasound expands the lining, so it kind of looks like this, and we're allowed to see the borders with that expansion and allowed to rule out, that basically allows us to rule out polyps, fibroids, adhesions, scar tissue, something that could be coming in the way of the embryo actually implanting, either for a structural cause or some type of biochemical cause. So a saline ultrasound is great to do up front if you've had a procedure in the uterus in the past, or a C-section, a D&C, or having irregular periods and having heavy bleeding because something structurally could be coming in the way of that lining coming back together. We always do them before embryo transfers, but I especially do them in my patients that have had, unfortunately, recurrent pregnancy losses, because there could be something at play that's a little bit more subtle that we just can't see on ultrasound. So if I'm evaluating the uterus, then a saline ultrasound is our go-to. The HSG is a little bit different. The HSG, I call it the tube test. People hate HSGs, and that's okay. We can talk more about that in a different live. We can do some HSG therapy. But the HSG is an X-ray study, and that happens, for us, it happens right here downstairs in our surgical center. But we put non-iodinated, so like clear contrast into the uterus, and yeah, it allows us to see your uterus still, making sure the shape is fine, and it kind of highlights these, what we call filling defects, so we can tell if there's something going on in the uterine cavity. But we're also able to assess the tubes. So is the dye flowing through the tubes? Is it flowing out of the tubes? Are the tubes thin? Are they dilated? Is something going on that could be preventing that embryo from rolling after fertilization from the tube into the uterus? I also like to think of the HSG as kind of like a tubal flush, where it clears out any small debris in the tubes and it boosts your chance of a natural pregnancy for the few months that follow that test. So I personally sometimes do both. I do the saline ultrasound and the HSG up front, depending on the clinical scenario. But most of the time, we do the HSG first, especially if this is your first visit with us.
Awesome. And we sort of covered this before. Those of our audiences that have just joined, we'll take a question that just came in, which is, what test do you recommend to understand my fertility? So
yeah,
a little bit.
Totally fine. So I think that this is something that, like, it's all over social media. It's like, do this at-home kit and take this supplement and all these things. And I think that that's a really hard thing to face, especially if you're scrolling on your phone and you're like, oh my God, I haven't done any of this. I didn't even think about this. What is this? There's some basic tests to really help understand your fertility. Not really until you start trying, until we face any issues or we're able to pinpoint one specific thing that could be coming in the way. But I always recommend doing a visit when you're starting to try, or even before you started trying, just when you're getting ready to try to conceive. And I recommend just basic tests. I like testing the anti-Müllerian hormone level, or an AMH. That tells me basically a combination. It tells me how bioactive are those small follicles that are released every month from this little kind of, the center of your ovary has all of the eggs you're ever going to be, that you were born with. It has about 1 million eggs when you're born. And then every month your body releases a certain number of follicles. The AMH tells me how bioactive are those follicles, or how should I dose you based off of how bioactive your follicles are. So I like doing the AMH, but I take it with a grain of salt. It doesn't predict your natural pregnancy. It doesn't predict egg quality. It doesn't predict menopause. If you go to my page, there's a lot of posts about AMH and misconceptions around it, because I think it's just so widespread. So yeah, we do the AMH. We check your other hormones like TSH, or thyroid hormones, prolactin, things that are coming from that little gland in your brain, your pituitary gland that actually sits behind the nose, and that signals over to your ovary. And we just make sure that there's nothing else that's coming in the way that's impacting your reproductive hormones. We, of course, obviously check your reproductive hormones to make sure you're exactly where you need to be and there's nothing that's coming in the way, or that your periods are not interrupted by some other hormones. And then we do some imaging studies. We do an ultrasound. We take a look for structural issues in your uterus, and then other issues like cysts in your ovaries. So those are like the big things. But yes, it's overwhelming. It's a lot. If we break it down, I think it's much easier.
Awesome. And then we have another question, which is a diagnosis of chronic endometriosis. What are the success rates after a treatment is complete if they're currently being treated with antibiotics for 14 days? And would a rebiopsy be necessary?
Got it. Okay. So in terms of chronic endometritis, so we are doing chronic endometritis testing, up front, in a lot of patients that have, there's a lot of different indications for it. But I think the biggest indication, and I'm sorry that you're going through this, but usually we do chronic endometritis testing if someone has had multiple losses, or has failed embryo transfers, or has biochemical pregnancies. So we're trying to rule out any inflammatory causes that could be leading to these pregnancy outcomes. Usually it involves a biopsy of your endometrial cells, and it's done usually at the same time of a saline ultrasound, but between day 6 and 12 of your period. And then we send those cells for testing, and we look for a certain marker called CD138. And if you have a certain number of cells, then we worry that inflammation is coming in the way within the uterus, and you get treated with 3 weeks of doxycycline, or there's other combinations. There's doxycycline and Flagyl. Some people do 2 weeks, some people do 3 weeks. Just depends on your provider. I always recommend repeating the biopsy. The reason for that is because we want to make sure, right? We've been through all this effort. You've been through the treatment. We want to make sure that it worked. We want to make sure that you don't need more antibiotics. With that, I will say there's more data that's coming out, and this is a constantly developing field, which is why I love it and I do what I do. But there is some recent data that's coming out that's showing that we should not be putting as strong of an emphasis on chronic endometritis. Obviously, we are the type of people as REIs, we want to look for any possible thing that could be coming in the way. And we do think inflammation plays a big role in pregnancy outcomes. But we're thinking that chronic endometritis might not be one of those big factors, although still do the treatment. I still recommend the read biopsy. It's up to your provider at the end of the day. But just know that there's more recent data that shows it's not that big of an issue compared to what we thought even just a few years ago.
Awesome. Thank you so much. And another question is, what should I expect at my first appointment with my doctor?
So at your first appointment with your doctor, usually it's a lot of like getting to know you. We're just trying to understand your history, trying to pinpoint. You're telling us your medical history and your gynecologic history, your surgical history, your social history for both you and your partner. And what your REI is doing in the background is going through this whole checklist of items saying, okay, what's a red flag here, or what's even a yellow flag here that I could pursue testing for to make sure that this is not coming in the way of a future pregnancy or a potential pregnancy. So a lot of it is a conversation. I also give my patients a lot of education at the first visit. So I'm a PowerPoints girl. I've always been a PowerPoints girl. So I always go through a PowerPoint. I don't go through, it's very personalized according to what patients come in knowing, but I like you to know why we're doing the testing that we're doing. And I like you to ask all the questions that you'd like to ask. So a lot of it will be education. So just wondering about what's going on. If you have any questions about the treatment options, about the workup, I show you pictures. And so you know exactly what to expect in the weeks to come. We also do an ultrasound and we do blood work at your first visit. Not every practice is like this. A lot of practices across the state, even in New Jersey and even across the country, will do a telehealth visit first. So that first part will only be a discussion with your REI, getting a history and then getting all the information. We also offer telehealth visits, so that's what my telehealth visits kind of stop at. And then you come in later and you do blood work and ultrasound, and then we get you scheduled for the saline ultrasound, and we get you scheduled for the HS. What to expect? I know, again, it's overwhelming. I always break it down. I always say there's 4 things that we do. It's imaging, blood work, a semen analysis, and counseling.
Awesome. Thank you so much. And then maybe we can talk a little bit about a pregnancy in late 30s or early 40s. What is your take on that? What should be done? And what does the science say, maybe?
Yeah. So first, I'm sorry. I know it's so hard at 36 years old with an AMH of 0.04 and a higher FSH. I know that you're probably being counseled in a lot of different ways, really to optimize your outcomes, but also to set realistic expectations. A higher FSH basically tells me that your body is giving signs of progressing towards being at the end of your ovarian reserve. The AMH is plus minus in terms of its role that it plays. It tells me that you probably need more personalized protocols where we're really trying to capture the follicles that you have that your body's releasing. So as long as you're having regular periods, pregnancy is still possible. But I would probably recommend you to talk to your doctor about the pros and cons of going through more rounds of IVF to hopefully get more embryos or bank more embryos and genetically test those embryos if you're able to retrieve eggs with that IVF cycle. I don't want you to lose hope. There is absolutely hope. I always tell patients, I will not give up until we reach your goals. It just might not be in the way that we imagined. So I want you to feel, open-minded, sending you a lot of love. This is a tough place to be. I think a higher FSH gives your body it makes it a little bit harder to respond to this. But there are definitely protocols that I trust that your doctor will discuss with you to kind of combat that as much as we can.
Thank you So much. The other question is, if someone had just gone through IVF and had a baby as a result of it, when can they go back for their second implantation or testing?
Great question. So I actually just had this conversation with one of my patients. Congratulations on your baby. I think that's great. I hope that you are recovering okay. Usually our standard guidelines say we should wait about a year from the time that we actually deliver, given that everything went well and that you feel good. You can start trying in about a year. Since you have embryos in the freezer, I think it's reasonable to start going through the workup and getting everything ready to go for your next embryo transfer around next November, December-ish, with a plan to do an embryo transfer as early as January. But depending on your findings, we repeat the saline ultrasound, we make sure the C-section scar is well healed. But depending on those findings, we might say it's better to wait a few months. So sometimes I recommend patients wait 18 months, but most of the time, 12 months is my mark to say, you're good, everything looks good, you've healed well, let's go right into an embryo transfer.
Awesome. Thank you so much. We're going back to a very popular topic today. For someone with secondary infertility and 2 miscarriages, should an SHG or SIS be first for their testing?
Yeah, I love all the conversation about HSG and SIS because I think that it's very confusing to understand, like, why are you doing both tests? Like, aren't they looking at my uterus and my tubes? And like, it just doesn't make sense sometimes. For someone that's had 2 losses, first, I'm sorry, it's a lot. There's no easy way around this, but I think just going through with the workup, which sounds like you are doing, is the right thing to do. I would recommend doing both, the HSG and the SIS. The reason for that is because we want to make sure that there's nothing in your fallopian tubes that's coming in the way. And keep in mind, your fallopian tubes can change a little bit between pregnancies and as we age. But the HSG and the SIS in the same cycle, if your doctor allows that. So most of the time I have my patients come in for the saline ultrasound around day 9 and then the HSG around days 10 or 11 or vice versa, just depending on scheduling. But these tests can be done in the same month. They just can't be done on the same day. But I do recommend both because they have different purposes.
Awesome. Thank you so much. And then we have time for maybe one last question. If you'd like to, I'll leave everyone with one thing that you wish patients knew before they start treatment. What would that be?
Sorry, can you repeat that? It just cut out.
Absolutely. I know. We were getting a little bit of static here. What is the thing that you would want patients to know before they start fertility treatment?
Yeah, that is a great question. So I think the biggest thing is to find a doctor that you trust and that you get along with and a practice that works for you. One practice that your friend used might not be the practice that works for you. And I think that that's really important to highlight. And it's also really important to highlight, like, this is an interpersonal relationship that you're building and you're trusting someone with your care. We want you to feel comfortable. And I think, again, like I said, I love RMA. I think all of our providers are amazing, are very in tune, very smart. I'm very lucky to be a part of this group. But I think interpersonal connections play a big role in your care. And along with that, and with interpersonal connections and feeling comfortable comes with, being able to ask questions and being able to understand why something is happening to you is so important. So don't go in thinking that you don't deserve to know answers, right? Make a list. I always tell my patients, make a list of questions. You can write it on your notes app at 2:00 in the morning if that's what works for you, or have a conversation with your partner, write everything down, take notes, and send them to us because we want to make sure that you don't feel in the world trying to conceive on your own. It's scary. There's a lot of unanswered questions. So our role as fertility doctors is to answer as much as we can for you. There's always going to be unknowns, but let us be there to guide you and don't be afraid to ask questions.
Beautiful. Thank you so much for joining us this afternoon, and thank you so much to everyone who's joined, who asked their questions. We will be having more of these live Q&A sessions through the rest of the year, so definitely check out our social media for the upcoming calendar, and always check out rmanetwork.com for a lot more information about all of these topics we discussed and many more. Thank you so much, Dr. Jain. Have a
Of
great.
course. And I was going to say, like, for anyone that doesn't have their question answered, I also host weekly Q&As on my page, which is Expert MD. So you can go ahead and like hop over, hit follow along. I do Q&As and I usually respond, within the same few days. So yeah, definitely keep the questions coming. I love it.
Love it. Thank you so much. Thank you so much for our patience.
Take care.
Have a great day.